right. Hey, everybody. We are here with Dr. Jason Smith, owner and operator of Utah Spine and Brain Chiropractic Neurology out in Bountiful, Utah.
That's correct.
Um, and Dr. Jason Smith, he has an amazing background. And for people that don't know him, he's an amazing resource within our functional neurology community. He's been in practice for ever since the late 90s, I believe. And he is not only a diplomate of the American Board of Chiropractic Neurology, but let me pull up more of your credentials here. You have your fellow of the American Board of Brain Injury Rehabilitation, a fellow of the American College of Functional Neurology. You're a fellow of the American Board of Vestibular Rehabilitation. You also have an advanced certification from the Spinal Research Institute of San Diego. And I know recently you and Dr. Rosenthal have been having a blast pursuing your master's in neuroscience through Parker University. So you are very well qualified to be teaching the beginner's track here. And we're super grateful for, your presentation last year was amazing, and all the information that you'll be presenting this year. You present it in such a easy, tangible way. So thanks so much.
My pleasure. It's so great to be here.
And again, thank you so much for serving on the board and helping our community grow. We really appreciate everything. So we're really grateful to have you. Can you tell our listeners and our everyone that's going to be joining us for the conference what exactly you'll be talking about this year?
Well, we've put together a different style of track learning for our introductory certificates here. And I basically had the idea that if we were able to focus on a certain part of certain symptomatology with brain injury, and then just focus on the symptom, on the anatomy, on the clinically, the important structural parts of the brain and the nervous system we need to understand, and then talk about some ways to examine it and then treat it. If we could do that all in one section, I thought that would be beneficial. And you'll have to be the judge to tell me if you think it's beneficial that way or not.
Well, absolutely. I mean, I've seen your notes. I helped out a little bit with the track one course. So I think also two people that took your classes last year got a little preview of what's to come. And everybody said, trying to learn some of this stuff. We've had people with backgrounds in neurology, and they said trying to learn it this way was a little bit overwhelming. And what you did so well was, just like you said, you kind of broke things down to be able to learn it a little bit easier and then be able to apply it a little bit easier, with creating the interest to dive a little bit deeper when necessary. So I'm sure it's going to be awesome.
Well, I hope you guys enjoy it.
Awesome. Well, thanks so much for being a part of this conference. And we will definitely hope to see you in person next year.
I look forward to that. Hello, everyone. It's great to be with you. I am honored to be here, and I'm just excited to share some fascinating information on one specific part of concussion that some of you may have not known about. But let's go ahead and get right into it. And hopefully you can see that there. And so the talk that I prepared for you today is something I've titled, Can You Differentiate Between TBI and Cervical Spine Injury? And the reason I've chose this is because so often in practice, we get certain type of cases that come in, and as those cases come in, we have a thought process on how that case should go. And sometimes traumatic brain injury cases, as you all know, don't always go as you expect. And so what I've put together is something that will hopefully help you achieve a few objectives. The first one is to help you understand that there's an overlap between traumatic brain injury symptoms and the symptoms of craniocervical ligamentous injury. I also want you to understand how the assessment of cervical spine disorders fits into the clinical evaluation of traumatic brain injury, and also how you can rule out clinical instability of the cervical spine. I also want to share with you some special tests and diagnostics that's in the research, and some of the validity and usefulness of those, and then some treatment considerations for treating cervical spine instability. So my first question for you is, what is your bias? Well, bias is a systematic distortion of the relationship between a treatment risk factor or exposure and clinical outcomes. And it's basically, that's what bias is. And there's three types of bias. As I've been studying this past few years in the Parker University Masters of Neuroscience, a clinical neuroscience program, I've learned about some of the bias types that can be found in research. There's information bias, there's selection bias, and confounding bias. And I don't really have time to go into all of those definitions at this point. For those of you who read Dutch, you can look up that study. But bias affects our ability to help patients every day in practice. So one of the biases that we deal with is some of the terminology that's being used. And Dr. Sharp from the UK wrote an article that I think everyone should read. And basically he says that it's time to stop using the term concussion. And basically he's recommending that because it's just such a confusing term and it doesn't have a lot of pathological meaning. But as you go through his paper, you'll find that one of the definitions of concussion or traumatic brain injury is based on symptoms. There needs to be an event, and then there also needs to be some symptoms. But if you look at the slide here on the side, this is showing concussion as a separate entity. And some people think it should be a separate entity. But if you look at the symptoms, headache, dizziness, sleep disturbance, cognitive impairment, fatigue, irritability, anxiety, and depression, those are all symptoms of concussion. But if you look at the symptoms of mild, moderate, and severe traumatic brain injury, you see the exact symptoms. So there's a Mayo classification. Mayo Clinic is recommending a different, slightly different presentation, but possible or symptomatic brain injury, mild, and then moderate to severe, which is a definite brain injury. And the reason why is because we're not seeing the evidence on imaging. And a lot of times in the medical world, we like to see evidence on imaging to be able to have a specific and concrete diagnosis. So one thing you need to know is that the mechanisms of brain injury are about, well, I would say exactly the same as the mechanisms for cervical spine injury. If you look at this picture, you'll see someone being rear-ended. As they get rear-ended, their head whips back, and then their head whips forward. And as their head whips backwards and possibly hits the head restraint, maybe not, you'll find that brain continues with inertia to move, and then it can hit inside the sharp areas. And if you look at the different density between the two types of neurologic structures in the brain, we have gray matter and white matter, and they have different movement differentiation. And where the gray matter moves differently than the white, you'll actually get shearing forces where axons get damaged. And that is something that can cause some microbleeding and some disruption of the communication of the communication from the periphery to the central and from the central to the periphery. If you look at the traumatic axonal injury, you'll see that there's different ways that axons can actually get injured. You can twist them, you can tear them, and then you can actually rupture and break them. And the image I like to use to think about why in almost every neck and brain impact that you have a likelihood of having brain injury is if you just sort of imagine a basketball sort of setting on a fence post, that you could get it balanced so that it didn't roll off. But the way our brain is connected, it's not centered. And so even if we were to get a shearing force in a perfect alignment from front to back, there's still twisting that occurs in the subcortical structures and the deep structures, as well as the fluid that's in the brain in the ventricles. So there's definitely an overlap in how the mechanism occurs in traumatic brain injury and in cervical spine injury. So let's just quickly review the definitions. Mild traumatic brain injury, a complex pathophysiologic process affecting the brain induced by biomechanical forces secondary to direct or indirect forces of the head. And, in this paper on cervical injury assessments, it emphasizes that the brain dysfunction is usually related to neurometabolic factors rather than structural injuries. And that's why we don't see those neuroimaging findings on those. So, as you all know, I try to educate patients to help them understand this. A lot of times patients will come in and they'll tell me a couple different things. Yes, I may have hit my head, or maybe I didn't hit my head, but I'm feeling weird now. And they're saying, well, I didn't have a brain injury because I think I might have just got a concussion. And that they're usually a lot of times using that judgment based on whether or not they lost consciousness. And really, the research is showing less than 10% of traumatic brain injuries that are mild report a loss of consciousness. As you go through the categories of traumatic brain injury symptoms, you'll find that there's basically 4 main categories, and then we'll talk about a really cool paper in just a minute that helps us expand our outreach and understanding of what is involved in concussion. So obviously, people who have brain injuries tend to have sleep disorders. They either sleep too much, too little, or they just fatigue. And I've been treating a handful of different concussion brain injury cases right now where they just have a difficult time. They feel normal at certain days, and then they'll do some mild exercise or they'll focus on their business or focus in school, and then they'll just suddenly crash. And it will take sometimes just a few hours, but usually several days to recover. And then usually how they know they're not recovered is they have some of these other physical symptoms. The light sensitivity is horrible, or they get blurred vision, or they have balance issues. And of course, headache is a big one. So the second page shows the 3rd and 4th category of brain injury symptoms. And basically these are emotional and affect issues. People who are more impulsive or feel anxiety and depression, and people who just sometimes just don't care. They have no motivation. As far as cognitive symptoms, difficulty concentrating and remembering are big, and especially people who have difficulty making decisions, and then you'll often see they just feel mentally foggy. So the question is, well, how long do these traumatic brain injury symptoms last? As the research shows, the symptom duration can be so variable from just a couple minutes to several months and several years. And I've seen concussion and brain injury cases as much as 15 years later where people are still symptomatic, and we're able to help them with certain approaches. So in this symptom burden paper that you see in the Journal of Science from Medical Sport, they analyzed and they used the post-concussion symptom score to show that those who had symptoms for longer than 28 days had a higher score, which is basically that Rivermead symptom score. They had a 42.5 score versus those that are 19.2. So those with higher symptoms intensity and number of symptoms tend to recover a little slower than those that have lower numbers. So I found another study that talked about the main symptom that predicts a delayed recovery. And this is a big one because a lot of TBI cases come in with one of these symptoms, and that's the symptom of dizziness. These 107 high school kids, they analyzed their symptom profile, and they found that the ones that recovered the slowest or had longest lasting symptoms usually included the symptom of dizziness. So the thing I want you to understand as I'm sharing with you some of these papers and some of this research is that in order to properly screen and diagnose and manage and treat these cases, you need to differentiate which symptoms are coming from concussion and which symptoms are coming from cervical injury. So we'll use those terms interchangeably, the concussion and TBI throughout the bulk of this lecture. So we do need to have some other definitions, and this is something that's very controversial in the literature. as I was preparing this, I probably went through several hundred brain injury papers, and then I think 67 on cervical ligament injury. And this next couple slides will just help you understand why it's so controversial. Now, the ICD-10 has a sort of a different definition compared to the DSM-5, and they call it post-concussional syndrome. And the criteria basically, you can diagnose this if it's within 4 weeks of the head trauma that they start to experience 3 of the following 8 symptoms. And that's the symptoms we've already mentioned, but one that's really difficult to quantify, and this is maybe why there's some controversy, is this last one, this 8th one, which is intolerance to stress and alcohol. It's just not really very easy to quantify someone's intolerance to alcohol, especially for some that don't even drink alcohol. So the post-concussion syndrome definition from the DSM-5, basically they need to have the criteria that matches neurocognitive impairment, which is a decline in cognitive ability, and they basically have to have a decline in memory, concentration, and or processing speed. They also have to have an evidence of traumatic brain injury with one of the following: either loss of consciousness, some kind of post-traumatic amnesia, either retrograde or anterograde, and then they have to have some disorientation or confusion, and then neurological signs, which can be numbness, tingling, increased frequency of seizure, or even onset of seizure. So there is some difference in these definitions, but usually, basically my definition is if someone has their past 3 months, yet they're still having at least 3 of these symptoms, and they had a history of a traumatic brain injury event, then we'll diagnose them with post-concussion syndrome in those cases that need a diagnosis for a third party. So what is the best tool for monitoring symptoms over time? When you're monitoring symptoms, I like to use something called the Rivermead Post-Concussion Symptoms Questionnaire. And that basically goes through these 16 different symptoms, but it's in a Likert fashion where there's intensity and severities, and also a way to say, oh, I used to have this symptom, but it's not more of a problem than it used to be. So maybe someone has a chronic history of headaches, and then they start getting more frequent or more intense headaches after a concussion event. Then you'd be able to track that. And I recommend doing this, administering this questionnaire to your brain injury patients every couple weeks in the first 6 weeks, and then at least once a month if you're treating longer than a few months. So why is it important to differentiate between traumatic brain injury and cervical spine injury? I think this is really important because there is, first of all, a risk of instability in the neck that gets worse over time, and then you can actually have neurologic deterioration, which could lead to catastrophic loss of neurologic function, paralysis, and so forth. The second reason is basically when you're diagnosing clinical cases, you want to have the most accurate diagnosis so that you provide different type of treatments for the proper treatments for the proper injury. So TBI and neck injuries aren't treated exactly the same, even though the symptoms are very similar. Neck injuries, if someone has a traumatic brain injury, they a lot of times have a recommendation of just go ahead and rest for a couple days to 7 days until they're symptom free. Well, in neck injuries, that's actually not the best way to heal from a neck injury. You should be up and moving. If you look at the whiplash research, and the evidence shows if people are wearing soft collars or more stiffer collars in neck injury, that's one way to almost certainly guarantee that you'll end up with chronic neck pain after a whiplash injury. So the activity recommendations are different. And then if you can localize this, if it's a primary brain injury, primary neck injury, or both, you can give appropriate recommendations. And a lot of times you can determine if you need to refer out or if you need to co-treat and co-manage the situation. So one study that I found, speaking of progressive instability, that you see listed below, they looked at 740 different patients with spine injuries, and they found that 30%, 29% of those with missed injuries developed permanent neurologic issues. So, and guess what the single most common error was? They didn't obtain an adequate series of cervical spine x-rays. Basically, in most of these cases, 31 out of 34, if they just would have ordered a 3-view cervical and had a proper reading of those, they would have been able to prevent that permanent issue to the neurology. So let's define what cervical spine injury is. Well, cervical spine injury is defined as persistent impairments caused by dysfunction of the somatosensory system of the cervical spine. And I just want to share with you a brief story about how I got into this whole field. When I was 21 years old, back in the early 90s, early to mid 90s, I worked in the University of Utah Physical Med and Rehabilitation Department. And I was what they call a lifter. And I basically, you can see my massive girth, I was able to take, and using biomechanics, I would take the cases that were there, and if they needed to go to rehab or they needed to go take a shower or they needed to get on the gurney, I was one of the ones that was called to help the nurses so they didn't hurt their backs. And I was exposed to so many unique and interesting cases. I was exposed to people who had neck injuries, who had halos. I was exposed to people who had massive rollovers, and they were in comas for several weeks. And then as they would come out, they'd be saying all sorts of, they'd be a little violent, and I was there to help with that. And then I would help with people who had heart attacks, people who had strokes, just all sorts of different neurologic disorders. And that's what really started me getting interested in helping people with this kind of scenario. So then in 2007, I learned about a diagnostic imaging technology and invested in that technology, and that started me down the road of helping hundreds and hundreds of patients be diagnosed with cervical ligament spinal injuries and instability, and then helping them get appropriate treatment that they need. So let's talk about cervical injury for a second here. What are the 4 most common symptoms? Well, neck pain and stiffness, headache, dizziness, and sleep disturbance. So the reason I put this slide up is I want you to understand that sleep disturbance can lead to cognitive deficits, which means if your neck hurts you from an injury and you can't sleep, it's going to affect your ability to concentrate, focus, and remember. So here's a nice little picture from the same paper that shows the overlapping structures that are involved in cervical spine injury and in brain injury. And obviously the muscles and muscle spindles feed back to the cerebellum, and the cerebellum feeds to the brainstem, and it goes up to the cortex. And you have all these areas that just feed into the brain that help you understand where you are in space. As this quotation says, the convergence of the C1 to 3 cervical afferents with the trigeminal sensory afferents of the head and the face and the trigeminal nuclei leads to referred hemicranial pain associated with cervicogenic headache. So you have headaches that can come from central structures, not necessarily from specifically injuring the brain neuron, because the brain neuron doesn't necessarily have pain receptors, but the dura does, the skin does, the ligaments do, the muscles do, all those tissues, even internal pressure in the ventricles can create a pseudotumor cerebri or a headache. So let's go to basically summarize. If we're only going to look at symptoms, can we differentiate can we tell the difference from concussion or brain injury and cervical spine injury? Well, the research is showing you cannot tell just by symptoms. So what can you do? If you cannot discriminate between post-concussion disorder and cervicogenic or vestibular post-concussion disorder, how can you figure this out? Well, you need to examine the cervical spine, and you need to examine the vestibular and ocular system to determine where they're coming from. So how do you differentiate it? Well, something the chiropractors have been doing for since 1895, or at least 100 years or so, is taking x-rays of the spine. As that one paper showed, just a 3-view cervical series can start you down the road and help you understand if there's any instability that's visible. If it's hidden, you might need to take some of these other views, the flexion extension, where you're bending forward and back, and then the open mouth views, which are much more difficult to do with plain film x-ray, but that's just basically tilting laterally side to side and taking an x-ray to see. That gets easier to do, and I'll show you how to do that a little bit later. So you need to correlate the complaints with the exam, with the diagnostics, and then you have to do some specific tests to determine if you have cervicogenic dizziness or balance deficits. So here's a few indications that I found that may lead you to think that you have some cervical instability. If you have the lesser occipital nerve getting irritated or compressed or inflamed, you can get that neuralgia there. If you get the second cervical nerve root inflamed, you can have neuralgia there, which can create a neuropathic pain syndrome. But if you look at the sensory distribution of skin on the ear, you'll find that there's several different nerves that cause that to be innervated. And so you can actually have a suboccipital injury that can radiate pain to the ear and cause ear pain. You can also have injury to the facial nerve or the trigeminal complex, and that can radiate pain to your face as well. A lot of the patients, I have a patient that I'm treating now, she's been treating her for a couple months, and one thing that she complained of when she first started coming in, she just felt like her head was just bobbling. It was just a bobblehead. She just felt like her head was weak, and it wasn't, she didn't have a good stable head on her neck. You should, and I don't have time to go over this in detail today, but you should make sure that you know the difference between upper motor neuron signs and lower motor neuron signs, because either one of these can actually be an indicator of cervical instability. If people have instability to the point where it affects their spinal cord, it can affect their gait, and a lot of times they get flexion, or without flexion, they can get paresthesias down the arm and leg because of instability in the neck. So one thing you should, if you've ordered the x-rays, you should measure these, or if you have a computer program that can do that, that's great. If you don't, you should send your x-rays out to get them read by a medical radiologist or a chiropractic radiologist who can do these measurements for you. But as you look at the AMA guides, especially the 5th edition I'm most familiar with, they basically tell you if you have an atlantodental interval of over 3 millimeters, then you should suspect clinical instability. If you have a segmental kyphosis of over 11 degrees, suspect instability. If you have an anterolisthesis over 3.5 millimeters in one direction, either forward or back, then you suspect instability. And then I didn't find any specific quantifiable numbers in terms of the AMA guides, but as far as the lateral bending, from the aspect of a neutral, if you're not bending and you have more than a 1 millimeter overlap of the C1 condyle on C2 pillar, then you suspect a fracture. But if it's neutral and you have everything lined up, and I'll show you a picture in just a moment, then you tilt and you get that sliding, then you know that there's some ligamentous injury, either the alar or check ligaments are compromised. So let's talk about a few of the non-catastrophic symptoms of spinal ligament injury. And these are primarily neck, but these can obviously happen in the low back as well. but we're just mainly focusing on the upper back today. So everything from neck and back pain to shoulder pain to tingling in the arms or legs to dizziness and visual disturbances to ringing in the ears to swallowing issues to breathing issues to bladder and bowel dysfunction to headaches and sexual dysfunction and chronic fatigue syndrome and myofascial pain syndromes, all the way down to hoarseness and sinus congestion. These are all symptoms that you could have spinal instability, and a lot of them overlap with concussion. So in this one paper, I think it's by Letty, I forget the author, but you can look that up if you're interested. You look at all the symptoms that are listed, and you see that here we have headache and dizziness and tinnitus and irritability, and we only have just a couple that don't overlap. So pretty much every concussion symptom and every cervical injury symptom that you can have, except for chronic traumatic encephalopathy. Well, this actually this should be an X here with some of the more recent literature that I've looked at. But the only other one that really doesn't compare is with concussion. You don't have a loss of cervical range of motion. But yeah, all these others, that's quite a few symptoms, 10 or 12 symptoms that all correlate. So you can't just look at the symptom and decide. Another paper that is a really good one to read goes through a whole list of symptoms from headaches to nausea all the way down to visual problems, including depression and nervousness. And they have these complex calculations and algorithms that I learned about in one of my courses last month that I didn't understand very well. But ultimately, even where it says significant difference, suggestive and significant, later in the paper, they basically debunk that and say there's actually no way that those specific symptoms can help you differentiate between concussion and cervical spine injury. So what we learn now is that concussion does not even require brain involvement in all cases. So you can get concussion symptoms from the neck. And the same type of trauma that you can get to that causes whiplash for you can injure your neck, but it can also injure your brain as well. So I found this really cool paper a few years ago, and I've started sharing it with patients because it helps them understand the magnitude of what a brain injury looks like. And I think a lot of people, when they have brain injuries, they're still getting treated like, hey, they're faking it, or there's no way you can have that many symptoms, or maybe they have a automobile collision that they were in, and now there's this thought that if you don't, as soon as the green poultice syndrome, if you just get the money, then all your symptoms will go away. And the research just doesn't bear that out. So there's this cool paper called the 7 clinical phenotypes of concussion. And this is something to just memorize and write on your whiteboard when you talk to your patients, and just say, look, when we're dealing with concussion, we have to rule out these different areas, from cognition to oculomotor dysfunction, to affect, to cervical spine disorder, which is really what I'm trying to focus on with you guys today. Obviously the headaches and cardiovascular problems, which is a whole nother lecture to talk about in the future, but conditions such as postural tachycardia syndrome can be a side effect or a result of brain injury and cervical injury. Of course, vestibular things as well. So all of those, if you can just remember coach CV, it'll help you note and make sure you just rule out all the different regions that can be affected. Now, the interesting thing, just for example, and this is why I like having these little papers to help me remember, but dizziness, when you study dizziness, there's over 100 different medications that can cause dizziness, and at least 13 discrete diagnoses that can cause dizziness, and probably 50. But oculomotor dysfunction, cervical spine disorders, cardiovascular problems, and vestibular problems can all result in dizziness. So most patients, when they, whether it's a child or an adult, if they have an impact or an inertial injury to their head or their body, and they start to feel like I've changed, I'm not thinking clearly, I have no energy, I can't sleep, I have headache or neck pain, something changes in their function. And that's where they'll start to go, okay, we've got these and these symptoms. And the first thing I like to do with an acute concussion in the first 6 weeks really is to have them fill out an acute concussion evaluation tool, which is we just call ACE in our office. And the reason why is if you look at that, it goes through each of the different symptoms in each of these areas, and there'll be anywhere from 3 to 10 different symptoms, and they can say 0, I don't have it since this concussion or this event, or 1, I have it, and then you just add up how many, and so it can give you, okay, you have 2 out of the 4 main categories of brain injury, and that can help you understand sort of how much brain involvement you have for the different brain regions. So what do you do in the office? Well, I'll just talk about what the research is recommending, and then I'll tell you about basically what I do. Office-based clinical assessment. The Berlin Guidelines recommends comprehensive history, which I think your ACE form helps you do. And that helps you look at the previous brain injuries, which we know second and third and fourth. And sometimes we've had patients come in with 14 or sometimes 20 different brain injuries. This is 25-year-olds with something, it's like they have almost a concussion a year their whole life. And some years they have a lot more than one. If someone has a headache history, they have a higher risk of having a brain injury. And if they have a neurodevelopmental history or even a psychiatric history, it can affect their ability to recover from an event. And then you do a detailed neurologic examination. So this is from the Berlin Guidelines. What should be included in your neurological exam? Well, you should look at the mental status. You should look at cognitive functioning, how their sleep cycles are, their eyes, their vestibular function, and their gait and balance. So this paper here by Cheever et al. Has a great summary of, it's an open free paper you can access on PMC, and it basically teaches you that there's these 5 main tests you should do to evaluate the cervical spine in every concussion case. And it includes a cervical joint test, the smooth pursuit neck torsion test, head neck differentiation test, the cervical flexion rotation test, and then the one that I bolded, which I think is more valuable almost than all of those, which is simple cervical spine palpation. So if you don't do cervical spine palpation, then refer to someone who can do it. So let's look at a few of the different upper cervical ligaments that can be involved in cervical spine instability. So this is the lateral view. Here's the dens, the second vertebra, also known as the axis. And then if you see right to the posterior, left is anterior, right is posterior, you'll see this yellow ligament called the transverse ligament. And I'll show you a different view of that in a second. But at the tip of the dens is something called the apical ligament, which goes up to the, I think that's called the basion. And then there's these other layers of ligaments. And this layer of ligament you see here is the posterior longitudinal ligament in the lower cervical spine. But as it gets up around C2 and C1, as it attaches to the occiput, it's called the tectorial membrane. And it has this vertical component and then a horizontal component as well. So it looks sort of like a cross, and it sort of stabilizes the posterior arch of, or this right behind the transverse ligament, and the posterior arch has been cut here, you see. So there's lots of structures in here that can create pain. And if you remember, all these neck ligaments, along with the muscle fibers, they basically send somatic information, somatosensory information to the parietal cortex. so you can consciously have understanding of where your brain is in space, and also it goes through the cerebellum to show you for unconscious proprioception, so you know where your brain is in space. But other ligaments that you can look at: anterior longitudinal ligament, of course the disc is a ligament. Then you'll see down here capsular ligaments, and these ligaments can all get torn and they can all radiate. Usually the nerves from C3, specifically C2 and C1, radiate upwards, and things basically C4 tends to radiate downward. So here's another view of the transverse cervical ligament, which is just comes right to the back. And this is really commonly affected in patients with Down syndrome or rheumatoid arthritis. The pannus formation in rheumatoid arthritis cases can actually cause swelling, and it can basically just rupture that ligament. And we'll show you how to look at that. So here's a lateral view of a CT scan, and you can see the cervical spine, and you'll see an increased space between the anterior tubercle of C1 and the dens. And once you get an atlantodental interval over 3 millimeters in an adult, then you know you have, I think from the research, if it's over 5, then you're likely looking at transverse ligament rupture. If it's over 3, it's partially ruptured or stretched. So it's a sub-failure, but not necessarily a full failure. Now this is a neutral view, and that space is increased. Usually you'll tend to see that as you do a flexion, you look at that ADI, that space in a flexion lateral cervical view, and you can see. But the problem is, as the C2 shifts backwards, that's right into the cervical spinal canal, and that's where you can compromise all sorts of structures that go to the arms as well as to the legs. So here's a recent lateral bending view that I did on a patient just a couple weeks ago. You see this AP open mouth view, and this is on the DMX. And this is a case that I mentioned earlier who had the bobblehead feeling, and she had basically been suffering with some pretty severe brain injury symptoms, everything from headaches to dizziness to constant nausea to inability to sleep, fatigue, all sorts of symptoms. And we were able to treat her, co-treat her with a vision therapist about 20, 30 minutes away. And he did an amazing job, but his vestibular ocular treatment wasn't able to be resolved until we addressed some of these issues here. And if you see this interval to the side, it should be symmetrical. And this is just the neutral. It's not perfect on her, but it's less than a millimeter difference. And then what we did is we tipped her to the right, and you see this pillar here shifts over, and it's, as I measured it, 3.4 millimeters, and on this other side, almost 2.5 millimeters. So I just do some dots there on my software, and we can measure that. And that was pretty much her residual. The last thing that she wasn't able to get full relief from is this upper cervical instability. And so we are working on helping her manage that now. So here's another view of some cervical ligaments. Anterior longitudinal ligament is here. The disc we mentioned, posterior longitudinal ligament. These are the capsular ligaments here, interspinous ligaments, and then in the cervical spine, it's a nuchal ligament or supraspinous ligament in the rest of the spine. So here's a little view of a flexion extension view with a sort of a cone down close-up view. And you can see from 2, 3, 4, there's some stretching at 4, 5, and 6. But as you look at the extension at C6, you'll see that that spinal posterior body line here is stretched, and that anterior longitudinal ligament is compromised, which leads to a 4.34 millimeter overlap retrolisthesis. So it's clinically unstable. It doesn't necessarily mean it's neurologically unstable. So what are some tests you can do? Well, this is something that's fun to do to help retrain people, but it's also good to help assess. To me, it's a diagnostic and therapeutic test. Basically, you put a laser on someone's head, and this is screenshotted right out of this paper. You just have them shine it at the center of that target, and then you have them close their eyes, and then you have them flex and come back, and then you mark it with a pencil where they come back to. Then you have them extend it and come back, and you mark it with the pencil, and then you have them rotate and come back and try to. You're basically checking the proprioception, and it's more of a general test. It doesn't say, oh, there's a specific issue at any specific ligament, but you're looking at the overall input to the cerebellum and the parietal lobe on how their head returns to neutral. So then you can just add up those scores and give it a baseline, and then you can do some treatment over time, retest it, and you'll be able to see that their accuracy improves as their vestibulo-ocular function improves and their neck stability improves. So there's another test called the smooth pursuit neck torsion test, which is seen in a lot of the whiplash literature. And in this test, you can do it sort of bedside, but most of the time I've seen the research shows that they need some technology and some specific equipment to do this, because what you're doing is you're looking at how the gain compares, the eye movements and the neck movements compare. So basically you just, the first baseline is you say, all right, here we are. You just have them do some smooth pursuit testing in neutral, and then you have them turn 45 degrees and you're off this way, and you have them do smooth pursuit testing, and you're looking for the smoothness of the eye tracking mechanism. And if there's end-gaze nystagmus with the neck turned at 45 degrees, then that means somehow that the neck is, proprioception is influencing the ability of the vestibulo-ocular system to function properly. Then you do it to the other side and compare. The research is a little boring when you look at this, but you can see the eyes moving right and left in this sinusoidal pattern, and then they calculate gain, and then they can determine in a trauma population versus a non-injured population, basically who's injured and who has either neck or brain injury as a result. So that one I haven't done a lot of in my practice. The head neck differentiation test is a handy one, more for determining cervicogenic vertigo versus other peripheral or central causes of vertigo like BPPV. And basically, it's very simple. The patient looks at a target and then sits on a spinning stool or office chair, and he turns sideways while he's looking at that target, and then he comes back and then comes back. And so he's basically holding the head still, and sometimes the examiner can help him hold the head still as he moves side to side. And if you can reproduce or create any of the symptoms, including dizziness, while they're doing this, then we know that some of those symptoms will be coming from the neck. If you move the head and you get symptoms, then you know that's activating the vestibular system. If you tilt the head, it can activate the otoliths. If you rotate the head, you're looking at semicircular canals. And there's a lot to be said for this one. It's very easy to do. I always do this on any vestibular case that comes in who may have cervicogenic vertigo. Now, this sharp purser test is one of the 5 tests that's in the literature. There's been specific studies, and I've listed those in the references, but basically the sharp purser test is done where you take someone who may be asymptomatic, and then you flex them forward to 20 to 30 degrees, and then you look and see if you get any neurologic symptoms. Could be numbness, could be tingling, and we're not doing full flexion at 50 or 60 degrees. We're just 20 to 30 degrees, which is basically an upper cervical flexion. And you'll sort of stabilize with the forehead, and then you're pushing back on the forehead while you have a pincer grip on the C2 spinous and the lamina, and you basically shear that forehead with the C2. And if you get a relief of the neurologic symptoms, and you a lot of times will feel a clunk, I've seen this in children sometimes, then you know that there's some instability there. But the validity, the safety, I don't know if we necessarily like to reproduce those myelopathic symptoms, but if you feel that little clunk, then that's considered a positive test. So look that paper up if you're interested. That's just a 2020 paper, a brand new one. So what do we do to treat cervical instability? The other experts can talk about a lot of the things to do to help with the brain injury symptoms, but what do I do to treat cervical instability? Well, gaze stabilization while I'm adjusting with an instrument is one of my favorite things to do, because it's so gentle and it's so light, and people get such rapid improvements. So here's how I do it. I didn't really explain it in my slide, but I'll just explain this. So basically I take the arthrostim. For those of you who are chiropractors, you know what that is. And it's just a pulsing, very low amplitude instrument. And I have people look at a target in front of the wall, or in front of them on the wall. Usually two different stickers. And I'll say, look at the blue sticker. It's just maybe, they're maybe a foot apart, maybe 5-6 feet away from them. And I find the tender spots, the joint capsules or the suboccipital structures, and I'll just very lightly impulse as they're turning their head maybe 5 or 10 degrees, still looking at that previous spot, and then I have them suddenly look to the next one, and then I have them go back. So I got this exercise from Dr. John Hatch in Provo, Orem, Utah, and he taught me this, and then I adapted it for this adjustment. You turn your head to the right and your eyes look to the left. And I'm adjusting the whole time. I might do that 2 or 3 times, and then I have people recheck, and it's amazing the amount of feedback that will help them with. So ×1 viewing is something that's very helpful. You can learn more about that from other vestibular rehab specialists, but basically you're looking at I like to have patients look at the center of the clock and then do some no-nos, just a couple, and then look at 3 o'clock and do some no-nos. And these are, once again, a diamond or a couple dots at each of those areas, and they just go from the different dots. And it only takes 20 to 30 seconds to go through a round. You might do 3 or 10 sessions a day, and that will help improve the accuracy of the feedback from the neck to the eyes. Make sure you avoid exceeding metabolic threshold when you're treating these cases. And you're not as flexible. You can't be as loose as you can with some other cases. But let's just say, what's interesting, I went from 3 to 5. So I must have deleted one. So it's really important when you're dealing with cervical instability to help people understand the value of ergonomics. If it's a lower cervical, reversal of a curve, or it's an upper cervical, a lot of times people look at their phones like this with their head just down, almost looking at their belly. If they do that, they are putting an immense amount of force on their ligaments or their torn ligaments. So I help them understand, look, put your screen height where the center of that screen is just below your eyes, so your eyes are slightly down, and then make sure you have armrest if you need it, so that you're not shrugging your shoulders as you're typing and creating extra neck tension and trigger points and myofascial pain in the neck. There's lots of research that relates jaw dysfunction to upper cervical dysfunction, and I almost always find some dysfunction there when I examine it. So I always help people understand, especially with people wearing masks so much lately, how I talk is different when I'm wearing a mask than when I don't. So I help people use some controlled jaw opening exercises with tongue stabilization. And basically, you know you need this if you open your jaw and then it shifts one side or it pops, or you're chewing primarily on only one side and you have asymmetrical tension on your masseters, your buccinator, your pterygoids. But this is really helpful to decrease some of the risk of headache. So stick the tongue on the roof of your mouth, slide down from the zygomatic arch, and do some opening and closing very gently, 2 or 3 or 4 as you slide down, and that can make a big difference for decreasing these temporal headaches and the trigger points that happen in the jaw. So I've had some pretty good success with retraining deep neck flexors, the longus colli and longus capitis, with doing supine or seated deep neck flexion. I think it's almost a little easier to do it when you're seated, but some people can only activate it when they're laying supine. And I like to take one of those neck stabilizer gauges, which will be on the next slide. And you just fold it in thirds, those blue things called a neck stabilizer. And you show the patient and you just pump it up till it's about 20 millimeters of mercury. And then you have them retract to just go maybe 2 or 3 millimeters of mercury. There's each little colors along on the gauge. And then you just teach them to not engage their SCM, not engage their platysma, not engage all the accessory muscles of respiration. You just teach them to retract and hold for anywhere from 5 to 20 seconds and relax and retract. And then you teach them to engage those muscles again. And that can actually help an immense amount of those with cervical instability, as long as they're not having progressive instability. When you look at number 8 here, scapular stabilization, use your Stroop bands or your TheraBands and teach people how to retract their shoulders and depress, or in a supine or a standing position with shoulder retraction and depression to engage the mid and lower trapezius, as well as the lat and the serratus anterior. And you'll find that it makes an immense difference to have cervical, thoracic, and scapular stability for these neck cases. Don't forget to mobilize the thoracic spine and the rib cage to make sure people are breathing. I've probably measured more, well, I don't know. If there's someone who's measured more of these than me, I pretty much measured this on every single case over the last 15 years. So I've probably done several 100,000 rib mobilizations, and I do it before and after almost every case if they need it. But most people like me to measure it, and then I adjust their rib cage in a seated position, elevate and open up their rib, usually the upper thoracic spine, and it makes their breathing number better. So that makes a big difference for the neck stability as well. So there's an example of someone doing some deep neck flexor stabilization exercises, just raising the head off the bench an inch or a half an inch. But most of my upper cervical injury cases can't do this because it automatically fires the SCM and too much upper trap. So I just like to use this neck stabilization device, fold it in thirds, and you can use that. It really works well. Trigger points is something we've added into our office, and we treat those almost every day. These trigger points, if you look at the new Travell and Simons edition 3 of their trigger point manual, the research is pretty substantial. We used to call it trigger point pain referral. It used to be pain referral. Well, the research is showing that you can get referral of all sorts of symptoms, not just pain. You can get numbness, tingling, tinnitus, all sorts of symptoms from these trigger points that have neurologic connections to the somatosensory cortex. So, what should you do to refer if you suspect instability? Well, you can order those radiographs that we talked about earlier, especially the lateral bending views. It really helps to have a digital motion x-ray, but the cost can sometimes be prohibitive for some people. But definitely get a 3-view cervical, add the 2 lateral flexion extensions, and then if you can get someone who knows how to do the lateral bending views, that can make a big difference. Once you get those, then connect with Dr. Kronk at Spinal Kinetics. And this is an unsolicited plug for him, but he has some great experience and a good quality company, and I've used them in the past. Sometimes you need to order an MRI, and as the research shows in just a second, upright MRI tends to show the cerebellar involvement a little differently and more often. So I'll talk about that in just a second. But you also need to have a good manual therapist. If you're not the one that does it manually yourself, then someone that can help the patients work through some of the symptoms and then teach them how to rehabilitate their upper neck and cervicothoracic spine. And then lots of the rehab specialists have lots of good work to do in the vestibular and oculomotor field. And then if a last resort, you can't get things to be stable and the symptoms to go down, then you can also consider surgical consultation. So I just want to conclude by sharing you this little quick case study, which is by Michael Freeman and some of his colleagues. Cerebellar tonsillar ectopia, which is a Chiari formation, and how that compares to head and neck trauma. So just to remember from your x-ray in school, the basion is here in the anterior. There's a pituitary fossa here, and the episthion is here at the back of the occiput. This is the lateral view of C2, C1 here, the posterior and anterior tubercle. So there's a line that you measure from the tip of the basion to the opistheon, and that's called McRae's line, or the BOL. And if you look, let's go to that one. You can see the cerebellum is here, and in this case, trauma, this is probably trauma-induced. It caused the cerebellar tonsil to be lower, and so almost certainly in this case, this person, because this is right where the flocculonodular lobe is, they're likely going to have symptoms of dizziness, maybe nausea, and lots of other equilibrium in their balance. So that's figure 2. And then if you look at figure 1 to compare, here's a different, it's not the same patient, but you see the cerebellum here and the cerebellar folia there, and then the McRae's line from the basion to the episthion, and you see that the cerebellum is above that. So that's one more thing to consider in your differential as you're talking about concussion, is you should rule out Arnold-Chiari formation. And read this paper, it's pretty good. They basically, this is a different type of CTE that we talked about in concussion, not the chronic traumatic encephalopathy, but the cerebellar tonsillar ectopia. And they basically took 1,200 cervical MRIs. Half of them were traumatic cases and half of them were not. And then they did half of each of those in an upright position and in a recumbent position. And then they had the radiologist interpret the scans and look specifically at the cerebellar tonsils. And they found that the ectopia of the cerebellar tonsils was found in 5, almost 6% in the recumbent, and 5.3 in the upright in the non-trauma group, versus 9.8 in the recumbent and 23% in the upright trauma group. So if you suspect it, it's quite a bit, almost 2.5 times more likely to find cerebellar ectopia if you have an upright MRI, which means you might miss it if you don't order an upright MRI. So that's something to consider. So let's summarize what we talked about today. It's been a fun time learning about cervical stability and brain injuries. My objectives at the beginning were help you understand the symptoms and also how you can assess the cervical spine and how those symptoms overlap. And then also how to perform some of the special tests, and then your treatment considerations and referral considerations. But most of these cases we can manage conservatively. I've only had maybe 2 out of well over 1,000 that we've recommended to send to surgery, and they need to get surgery to get it stable. There may be some bias in my case because of, the way the more serious injuries sometimes already have had surgery. But I've really enjoyed sharing this information with you. I've learned a lot, and I hope you were able to get at least introduced to some of this information, and hopefully it's interesting to you. And just remember, just keep getting better all the time, because there's a lot to learn and the research keeps coming. Just keep reading the research and practicing with patients, and stay in the game, because there's a lot of people that need help, and we're the ones to do it for them.
All right. Well, Dr. Smith, thank you again so much for being a part of this year's conference and all the information that you shared with us. With all those books in the background there, I know that you're an avid learner and you've probably figured out some amazing ways to retain this information. Could you share with some of our learners some ways that you have found that have made making this stuff stick or more plastic in the brain a little bit easier for you?
Yeah, I mean, I've done so much education and so much learning the past, even since I finished chiropractic school, that I've just been really frustrated at times with why I'm not able to retain it. And so what I've done is I've made a study on how to learn. And I've definitely tried to learn how to make neuroplasticity happen with patients, but I've definitely wanted to make my own brain healthier. And so what I've put together is just a little research that you can see if I can share my screen, and I'll just show it says I'm disabled from screen sharing.
Because we can edit this. Brandy, if you see this, can you edit it to where he shares the screen? Thank you. So make host. Now,
Okay.
can you?
Yep. So let's look right here. So if you look at this little video of my granddaughter about a year ago, you can see she's just barely starting to learn to walk. And it's always so fun to see a little baby learn to walk, that it's just so much joy. And if you notice, what we're doing in traditional learning is, it's crazy how we force ourselves to learn. First of all, we isolate ourselves away from everyone so we don't get interrupted, and then we deprive ourselves of all sensory input, and then we sit there in one place and we don't move around, and it's all based on whatever this teacher decides I need to know and learn that, and then they give you that information, and then there's a whole bunch of written tests, and then you just procrastinate because you're so busy and trying to learn so much, and you cram it in, and then you of course quickly forget it all. So if you want to learn how to learn, I really recommend this course by Barbara Oakley. It's a free course on Coursera.com, and it basically talks about the two different learning styles, how you can have diffuse learning or focused learning. And between going through her program and learning some of the other things from some of these other courses, I basically put together 5 ways that I think is a beneficial way and a helpful way for me to learn. It's been good for me anyway. And the first one is just to follow a path. You see my son hiking here up in the Uintas in Utah, and it's just beautiful as long as you stay on the path. If you get off the path, you get a little dangerous. So you stay on a track and you do it steadily and consistently. And then the second one is you visualize and draw your knowledge. With all the technology we have, everything's just so easily accessed, and we're not taking notes as much as we used to. But if you do take time to draw things out, it will cement that knowledge in your brain. That's sort of goes into point 3, which is how it's important to learn spatially. And that means you take things with your body, you make diagrams, you make charts, you make flow charts, you reword the things that you're learning, and you put it into something that makes sense, where you can review it and cement that in your brain. And the 4th thing is, it really helps to learn socially. If you have someone that you're a study partner, an accountability buddy, or something that you're like, look, let's study this topic for this amount of time, and then you once a week check in and you share what you've learned. If you don't share what you've learned, it really accelerates the amount that you'll forget. So that's one thing that I've loved having a chance to teach, because I really learned this material a lot more deeply. And then the fifth one is really critical. It's the chain over here. You have to link what you're learning to something that you already know. So maybe you understand how bungee cords work, or rubber bands, or block stacking. There's just find ways to link physical truth in your mind to what the new things you're learning, and you'll find that all of a sudden it just sticks there, and then you're not wondering, hey, what was that thing I learned? So if you follow a path, you visualize your knowledge, you learn spatially, you learn socially, and then link your learning, and then just share it to people, teach it. You'll find, and of course, if you're seeing patients, you have a chance to teach it to your patients every day. So every single day I'm studying, a little in the morning, a little bit at night. Sometimes it's only 5 or 10 minutes, sometimes it's an hour or two, but I always share what I'm learning with my patients, and I tell a story about that thing that relates to them, and it seems to make a big difference. They seem to like it, they have fun with it, and then they start to benefit from the things I'm teaching them.
Well, that's awesome. Thank you so much. And can you just show that website one more time for people on the first slide from
The
Coursera?
website, this is amazing. It's Coursera.com. And this one is probably one of the most watched courses that's ever been. It's been watched by multiple millions, but it's called Learning How to Learn by Barbara Oakley. And it's just really nice because it's a brain-based approach on how to maximize your learning. And it'll take you, I don't know, 14, 18 hours to go through it, but I just went through it 30 minutes a day, and there's little videos and little quizzes to help check your learning, and it's a fun course.
That's great. Thank you for that resource, and seriously for all the information, and of course all that you do for IAFNR. Thank you so much for volunteering your time on the board, and we look forward to what's in store for the next year. So thank you so much.
Hopefully we can get to do something in person, which is
Yes,
part of the social learning and
social learning
connections.
Absolutely.
Awesome.
Thanks so much, Doc.
My pleasure. Thanks.